afternoon. I'm Dr. Caldwell, and I'm going to be talking to you this afternoon about repersonalizing clinical care. It's a small audience, but I'm happy to speak to, as long as there's one person in the audience, I'm happy to speak to one person. I'm a clinical tutor in the trust here, and I'm also a general physician with an interest in diabetes and endocrinology, working up on general wards. So most of what I'm talking about is ward-based care, and it's predominantly, I think, directed at doctors, though I'm sure what I'm saying is of significance to nurses and allied healthcare professionals as well. Start by talking a little bit about the Egyptian and Greek traditions of medicine. In ancient history, the Egyptians and the Greeks had two different approaches to medicine, and the Egyptians were very factual in their approach. So if a person had a head injury and was collapsed unconscious on the floor, the Egyptians gave very specific instructions about where to drill into the skull to try to evacuate the hematoma in the hope that the patient would recover. Whereas the Greeks were much more storytelling in their style. So they'd tell you about the carpenter who'd been sitting inside his house trying to do his woodwork when the rain came through his roof, ruined his woodwork, so he had to go onto the roof to repair the tiles. And when he was on the roof, he fell off the roof, crashed to the floor, was unconscious, and his wife came home from the temple, took him to the doctor who drilled into his hole and evacuated the hematoma, and he recovered. So the Greek tradition is very much a storytelling tradition of medicine. And at the end of this talk, I think you'll see that I'm very much a member of the Greek medical tradition, that I like our cases to be stories because I think that human beings learn from storytelling. Now every now and then, or it seems quite commonly, we see events happening around about us in the world that just make us think that's plain wrong. It's inhuman. How could human beings behave like that to other human beings? So what's happening in Kurdistan, North Iraq at the moment, Syria, Palestine, the Twin Towers, Bosnia, Uganda, Rwanda, Cambodia, Vietnam, you can see going back in history. South Africa and southern USA during the civil rights movements, what happened in Germany when we bombed Germany, when the Americans bombed Hiroshima. Inhumane events that make us think that's plain wrong. And how can the human race do this to each other? On a smaller scale, it may seem, we've seen inhumane events happen within the NHS. So in Maidstone and Tunbridge Wells hospitals, certainly within the last decade, there were 90 excess deaths from C. difficile. And when you read the reports from Maidstone and Tunbridge Wells, most people recoiled and thought, that's inhumane, what happened to those patients? How could that happen in an NHS service? That seemed bad enough, and then we had the Mid-Staffs Hospital, where it's thought there's somewhere around about 1,000 excess deaths in that hospital from events that sounded to us outside Mid-Staffs as inhumane. How could these things happen? For example, patients left unwashed, unfed, and without fluids due to NHS failure. So how can caring staff come to treat people inhumanely? Or was Mid-Staffs populated by a strange group of NHS staff who came to work every day to treat people inhumanely? I very much doubt that. And after the Second World War, I think psychologists became interested in how can ordinary human beings start to behave inhumanely. In the Milgram experiment, people were recruited to take part in a psychological experiment, and one of the pairs of the people in the experiment was told to inflict electric shocks on the other person if they got answers to simple questions wrong. The person administering the shocks could be persuaded to administer shocks that would be enough to kill people. Of course, one of the people in the experiment was an actor, so when they delivered the 600-volt shock and the person collapsed on the floor, he didn't really die, but the people involved in the experiment were persuaded or manipulated, you might say, to behave inhumanely. Again, I think it's mainly through in Germany and Australia and America where they've started to look into compliance, what happens when we're asked to do things by people who seem to be in authority, who have some degree of power over us. So compliance only needs a leader or a follower and the leader giving permission. And of course the successful functioning of society depends on us being compliant to things like obeying the speed limit, not drinking and driving. But in the Milgram experiment and similar experiments which have been carried out around the world, it seems that somewhere around about 60% of us can relatively easily be made to comply with harmful actions. And of course, everybody in this room, and me included, would think, well, I'm not one of those 60%, I'm one of the 40% who would, of course, stand up, make sure that everything was done right, and I wouldn't be compliant. So the film Compliance is set in a fast food store in America, where one of the staff is accused of stealing some money. And there's a police officer outside in the police station, in the precinct, who makes all the other staff do terrible things to that person who hasn't committed the crime at all. And it seems fanciful, but it's believed that 30 or 40 similar events actually happened in America. That people falsely accused somebody who said they're a police officer manipulating information out of people, making ordinary human people behave in an extremely cruel and inhumane way to other people. Das experiment is looking at, again, recruits to psychological experiments where one group is put into be the prison warders and the other the people who are in prison. And the experiment's having to be stopped because people within that experiment got so cruel to each other. And in the wave, and you may have seen in a school where people started to behave in a compliant way, replicating this and getting very violent and aggressive towards each other in the groups. As I said, the usual reaction then for people like us who are in caring professions, who come to work each day to try and do the best for our patients is, it wasn't me, I didn't do it, we're not mid-staffs. I think it's a little bit unfortunate that when the Francis report came out, there was something like 300 recommendations specifically of what we should do, rather than ask ourselves, what is it we're trying to do, what can have gone so badly wrong that we've got to the stage where we're treating people inhumanely, and is there a different way to try and approach this problem? So, moving it down the scale, obviously this is nothing like what happened with the bombing of Hiroshima or the terrible atrocities that happened in Auschwitz, but have we ourselves ever been compliant beyond what's best for the patient? So, when the 4-hour A&E target came in, that seemed to us a reasonable target. We wouldn't want to be in A&E longer than 4 hours ourselves, waiting for a bed. We'd like to have our treatment and diagnosis given within those 4 hours, and then moved on to the appropriate place of care. Shortly after that target was brought in, I saw senior nurses who I respected greatly for their clinical skills, moving people out of A&E just because we were going to breach that target. It wasn't time for them to move, there wasn't necessarily somewhere appropriate for them to move to, and yet we complied with that. Both the nurses who are doing it and ourselves as consultants didn't stand up and say there's a small number of people where they have to stay there for their own safety, and that it's dangerous to send people downstream to the wrong wards. Even this year, which is many years after the 4-year target's been brought in, I've had 2 patients moved to the clinical decision unit, which is meant to be a unit for people who are relatively safe and stable. I've had people managed in there who've got septicemic shock. Now that again is not right, and we're compliant with it because we've got people in authority saying to us, if you're not compliant with that, we'll get fined and you'll threaten the financial viability of the organisation. So I've put it to you that there are cases where we're perhaps compliant, it's not in the patient's best interest, somebody in authority is telling us it's the right thing to do, and we're going along with it without saying it's wrong. So maybe sometimes these things we have to do them, but we should still be saying it's wrong even though we have to do it, rather than accepting that it can be satisfactory and okay. So I think whether targets and rewards are taking priority over personal patient care is where we can run into difficulties. So another example, we've talked about the 4-hour target and the use of CDU for patients who are inappropriate there. Night bed moves. So in our hospital, we move a lot of people overnight and at weekends from their only place that's got some semblance of home to them, which is their own bed, their own surroundings, and move them to another ward. Now we do that, not for that person's personal care, but to meet a 4-hour target, or to balance the male and female bed numbers, or to reduce the C. diff rates. But we break our own rules whilst we do that. We're told we shouldn't move people who have dementia and people who have delirium. Now, at least 30% of our inpatients have dementia or delirium, and again, I've seen many of our patients with dementia or delirium moved for no personal advantage for them. So again, bed moves may be necessary, but do we recognise them as wrong? And do we apologise to the patients about them? Do we fully explain them to the patients? On the ward round I was on this morning, there was a comment from one of our nursing staff which implied that a patient was a bad person because over the weekend he'd refused to move beds. So again, I would argue that we're perhaps being compliant with these instructions and commands above the personal patient care, and got to the stage where we don't even think of it as wrong. It's so ordinary to move people at night, so ordinary to move people off ITU at night, to move them at weekends, that we've got to the stage perhaps where we don't even recognise it as wrong because it's so ordinary. Compliance with well-meaning targets can undermine personal and human clinical care. The wrong priority focus. I've been asked to fill in dementia screening forms whilst in the middle of medical emergencies. And that's to make sure we don't lose money, we don't get fined for failing to do the dementia screening. VTE prophylaxis, perhaps a little bit more controversial, but if VTE prophylaxis is such an important thing, why haven't we seen a major drop in DVT and pulmonary embolism since we moved from 5% compliance to 95% compliance across the UK? So it may be the wrong priority to be making us fill in forms, return statistics, keep up with the VTE prophylaxis. Maybe we should have invested all that effort into something more important for our patients. I think the question of patients being on pathways is really important. In general practice, I was talking to a general practitioner last week who made a patient write a statement that she was refusing clinical guidance on best management of her atrial fibrillation. The patient didn't want warfarin at all. All the evidence in medicine suggests she ought to take warfarin, and to cover himself and to make sure that he was all right, he made her sign a form saying that she was refusing best clinical guidance for her care because the GP was frightened he was going to be told off for not following guidance. So an attitude, a frame of mind within us, we've got to do this because we're being told to, over the personal relationship with the patient and the patient autonomy. Patients on pathways, particular pathways, fractured neck of femur pathway, acute coronary syndrome pathway, community-acquired pneumonia, stroke, again, we're likely to increase our income if we manage them carefully, lose our income if we don't manage them carefully, and the people who don't fit nicely into one of those pathways may get secondary care, may get inferior care because we're concentrating so much on the patients on pathways. I think I've already suggested that we can sometimes see our patients as fines or sources of income, which I don't think is a healthy attitude for individual clinicians to be having. And of course, if we regard our patients as litigants right from the outset, we're going to be very careful with our patients, very impersonal with them perhaps, and mainly concentrating on documentation rather than clinical care. There are other areas where I think I see around the wards where the emphasis isn't on what I'll get to, which is what I think we really should be doing. We get the wrong priority focus. So all the paperwork has to be filled in completely, immaculately, and totally and right. So we have to fill in the Waterloo pressure assessment form, fill it in completely, get it right, get the right mattress in place, rather than seeing the patient needs the mattress, get the mattress in place. Lots and lots of documentation. And I think if you're on the nursing side, you'll know that there's so much documentation that sometimes you simply cannot get on with the work that you want to do because you're having to document it. Mandatory audits ahead of treatments. I can remember there was one time I was on the acute medical unit and James Walker couldn't be with us on the ward round. When I asked James, he's a very senior charge nurse, when I asked James why he couldn't be with us on the ward round, he was doing an audit of whether people were in single-sex bays or not. That audit could have been given to a 16-year-old, or probably even younger than that, to conduct that audit, not somebody with the great expertise of a charge nurse who could be there contributing to the care of patients. So I'd argue that's the wrong priority focus, but the message coming through from those in authority was that that mattered more than being on the ward round at that time. Again, we've got this big pressure throughout the NHS currently. Don't admit people, send them home early and empty the beds. And again, that depersonalises the care. These are people who are occupying a bed that they've got to get out of as quickly as possible, not somebody you've got to treat really well, make their health as good as possible, then get them home right on time. And fill in the Datex form, report the incidents, rather than fixing the problem so it doesn't happen again. Other things that tend to lead to depersonalisation, which I think most of you will recognise now, task saturation, simply having too much work to do. If you've got too much work to do in the time that's allocated, you're going to rush and resent the next piece of work that comes in. So I know some of you here from radiology, you're under intense pressure all the time, us coming down saying our patient's the most important, get these x-rays done, get them reported, get the scans reported, do some more, and you're just working flat out all the time. So if you're working flat out all the time, there's no time to stop, to have a break, that will make you more likely to behave in an inhumane way. Too many patients. I met somebody this morning doing a ward round of 27 outlying patients. I don't think you can do 27 outlying patients in a morning and give them good care. So task saturation, too many patients. Shift working and handovers, I think, had an enormous effect on medical care. Nurses much more used to handovers, but I think the shift over to the 12-hour shift in nursing, so nurses weren't there 4 or 5 days in a row, just 2 or 3 days in a row, and our handovers, again, moved us towards depersonalising clinical care. If you get no breaks, no social time or space, the team will be dysfunctional. It won't be a happy team. I think we went 18 months without having a coffee break on our ward rounds because we're always seeing 25 to 30 patients on our ward rounds. So it started at 9, finished at 1 or just after without stopping. That will make you feel like the last patient perhaps doesn't deserve the same care the first patient did. Ordinary work requires too much effort. I think we know that very well in our organisation. Our IT systems make ordinary work, like seeing an x-ray, a potassium result, an HbA1c result, and an ECG, really hard work. You're an associate allied healthcare professional, finding the notes, trying to understand what the doctors wrote in the notes, really hard work. So ordinary work is too much effort. No one saying genuine thank you. Hard work today, good, you've done a good job, thank you. If that's not happening, we'll feel undervalued and we won't be able to give the care we want to. Command and control, very elementary approach to trying to organise complex organisations. Command, control, bullying, undermining, blame and retribution. To feel situations out of control, shout at people and tell them off and hope it comes under control, doesn't work for complex organisations. Doesn't work for professional working and will make people feel undervalued. Repeated NHS staff surveys, 25% of staff, NHS staff feel bullied by their own line manager or management team. So it's not something we can ignore. So how can caring staff come to treat people inhumanely? How can they come to turn it around and make it humane? I think our priority work for all of us, working the teams that are providing care to our patients, is to try and establish a professional and personal relationship with each patient. That for each patient we should be identifying the diagnoses, comorbidities, in each unique person, each unique setting. And with our patients, respecting their autonomy, which is the right to decline treatment, agree and implement a unique treatment plan for each person. And the overall aim there is to make the person better, or better able to cope with their illness or to experience. And for those who are dying, that we want to help them to experience the calm end of life. So that's what our work is, and I hope people in this room recognise that's why they come to work, whether they're chief executive, a person who cleans our toilets, a staff nurse, a consultant. That's what we're trying to do. That's what we're trying to do. It should be very clear in all our quality measures, all our priorities and all the pressures that are put on us, that that's the top stuff that we've got to be doing. So it may seem that there's little hope for repersonalising clinical care. With all those pressures on us to try and meet targets and to avoid fines and to get appropriate rewards, to meet the hours of work's target, is there any way we can protect ourselves against this? And I'd say that we should be repersonalising our clinical care. Know the person before you make the person into a patient. As a medical student, I was told, don't get emotionally involved with your patients, which actually I think meant don't have sex with your patients. And why somebody didn't just say that would be much clearer. And ask about the occupation in case it's an occupational disease. So if you weren't interested in being emotionally involved with the patient, having sex with them, and the person was retired, there was no reason to be interested in the person beyond their diagnosis. Whereas I think what we should have been told is just know the person. Because I think all these other things I'm talking about label the person, and you're giving them a label before you've recognised them as a person. So if you recognise on your ward handovers, your ward rounds, that you're talking about this 85-year-old man, the woman in bed 3, the diarrhea case in bed 7, I can't remember her name, but the morbidly obese woman, that sort of way of describing people, we've forgotten who the person is. I found that it's rare in our clinical inpatient notes now even to find the occupation. And I suspect that's because most of our patients are retired now, but we don't even ask them what their occupation used to be. Let alone anything personal, anything about their interests, anything about them. We had a man last week who had had psittacosis many years before, so there was a chance for a conversation then about was he a parrot keeper and did he still keep parrots and things like that. I've looked at the incoming referrals to me for my outpatient clinic. I've looked at 224 consecutive referrals to my outpatient, letters from GPs, colleagues, whatever, and there's only anything personal beyond their age in 10 people, and quite often there wasn't even the age, you had to sit there and calculate it. And the 10 people where they said something personal, there was only one which was anything possibly outside medicine, and that was that they worked in a counselling shop in Chichester. The rest of the other 10 were things like, this is a staff nurse, this is somebody who worked in cardiology. So it wasn't anything really personal. And most letters are addressed in personally now as well. So choosing book system, the GP can no longer write to me, dear Gordon, although some of them did. Most of them it's dear colleague, dear endocrinologist, or not even dear. Just, can you see this patient with an overactive thyroid? Nothing personal, no connection. So when I'm working in outpatients, and I try and remember it on the wards, and sometimes it comes right at the end of the consultation when we reviewed the patient, before we talk about your health, tell me something about yourself, work, family, or interests. And usually within about 30 seconds, somebody can tell you something you can make a connection with. Or on the wards, I sometimes pick up on an accent, ask where the person is from. And this way you can find endless fascinating people, which I think just answers our curiosity, but also helps us to remember who the people are, and to remember that they are people. So how can knowing the person help? I think one of the things, it can just make work more enjoyable. So Sunday, about a week ago, one of the patients on the ward round had been a trapeze artist, and she was 78 now, and I'd never had a patient who was a trapeze artist before, and she'd had some chest pain. But she'd also had both her hips replaced. So I asked her, was osteoarthritis of the hips a consequence of being a trapeze artist? And she said, no. She, when she was 2 years old, had congenital dysplastic hips, both sides, and spent 2 years in a spica cast, and then became a trapeze artist. And she said, and now I'm 78, it wasn't for this chest pain, I go dancing every day of the week. And this was really important for me because my 3.5-year-old granddaughter just had surgery for dysplastic hips on both sides. So I would say to her, I can go home to my granddaughter tonight and tell her she can still be a trapeze artist and dance till she's 78, even though at the moment she can't do it. So that makes a personal connection, makes the work more enjoyable, and means you've got more connection with the patients. I think talking about bed moves, again, knowing the patient can make a big difference. I had an external consultant came on one of my ward rounds. The third patient we saw was 83 years old and asked us if she could have her breakfast. She had been on 5 wards in 3 days in our hospital, and she had renal failure, and she was scheduled for an ultrasound scan. Eventually we found all that out, we'd sorted it all out, and she knew she had to wait till lunch to eat. But I asked her what her interest in it was now that she'd retired. And she knits the little hats for the babies in the special care baby unit to keep them warm. Now, if you'd been a bed manager, would you have moved that woman happily, knowing that she spends her life knitting the hats for our babies on the special care baby unit? So I think it would influence how you behave with people, knowing that bit more about them. Sometimes it can cure people. The chap I'd been talking to on the ward had been there for 2 weeks flat out on his back with back pain, and I spotted his Geordie accent, and he was from Concert, where I'd worked as a local consultant at one stage, and I'd remember all the smoke and the steel mills in Concert. So we talked for about 3 minutes about the North and about Concert and about steel mills, at the end of which he said, well, can I go home now, Doc? I said, but you're lying there in terrible pain, you can't walk. He said, no, I'll go home now and have my investigations as an outpatient. So sometimes a connection can have a big impact on people's psychological approach to their own illnesses, I think. This happens, I think, because personalising care helps, well, personalising care also helps in diagnosis. I think if you make that connection and open up a relationship where you're obviously interested in the person rather than just in the diagnosis, that brings in trust, openness, and the person is likely to volunteer you a better history. They're going to tell you more about themselves, they're going to be more confident, particularly something embarrassing or intimate. They're much more likely to do that if they believe that you're interested in them beyond just the diagnosis. I think it will improve your empathy, increase the drive and commitment because you're interested in this person, and as I've said, improve your enjoyment of work. So perhaps we need some new quality measures. I was a bit scathing about VTE assessment. At least that showed that we can organise ourselves as the NHS to do something we never did before and to change from 5% performance to 95% performance. So we've got good infrastructure to make changes. Maybe what we should be measuring is there some indicator there of who the person is, something personal about them, something you can help to remember them by. Then, have we made a highly personalised list of diagnoses and problems? I walked past David Hunt on the way to work this morning. If you look at David's lists of diagnoses and problems on the frailty assessment unit, they go on about this long, and for everyone, there's a plan about what you're going to do. So each person is getting 30 problems addressed with an action plan. That sounds like highly personalised, highly professional clinical care to me. So if we measured the length of the problem list and the number of actions we're taking, David Hunt would be one of the best physicians in the hospital because he's doing what I think we as clinicians should be doing. Have we negotiated that personalised management plan with patient autonomy, and have we done it? And kept the patient under review. Now, I think this is the area where I'm really poor, which is about personalising our work relationships. I think I usually go onto the wards, I don't recognise new staff, I don't ask them just about themselves, I don't find out who they are, and I'm really poor at remembering people's names. So to know something extra about the staff that we work with, to make that personal. When I'm doing a post-take ward round, when it's a new doctor who's working with me, which is nearly every week, I'll take just a couple of minutes to ask who they are, where did they study, did they do an extra degree on their way through, what are their career ambitions, what are their outside interests. And they'll often say that it's the only consultant who's ever asked them a question like that. And again, you can just find bits that you can use. Last year we had a foundation year 1 doctor who'd studied Japanese and worked as a Japanese translator in Japan as one of our members of staff. I never knew about that before, and obviously if we'd happened to have a Japanese patient in, that could have made a big difference to that patient. But just knowing these little things about your staff makes a big difference before the work starts. So the success of the World Health Organization operating theatre checklist, I think, depends on the fact that people introduce themselves to each other. Once you've introduced yourselves to each other, you've got some connection. You're more likely to tell the person who's introduced themselves and been kind to you that they're about to cut the common bile duct instead of take the gallbladder out. So it can have an impact on how we work. Now, I think it's quite obvious, if you repersonalise care on that basis, it won't protect us against all those forms of harm and influences that exert themselves on us in our relationships with the patients, but I think it will help to protect us, make our patients more memorable, make diagnoses more accurate, increase our enjoyment of work, and will make us more committed to individual personal care. So here's some examples just from the last 2 or 3 years. There was the 75-year-old man up on Coombs ward with very high calcium levels, driven by an overactive thyroid, who we later found out to have complete pituitary failure. So a very odd combination of clinical things, which were very interesting themselves. I asked him what he had retired from. He said he wasn't retired. He was on the phone that morning to Japan telling them how to decontaminate their nuclear power stations after the tsunami. So I thought better get his health sorted out because it's quite important for the rest of the world. Bed next to him was a 68-year-old man, hardly able to talk, newly diagnosed with COPD, who had been the cameraman on every James Bond film that had ever been made. Nobody had found that out. We had an 85-year-old man down on the acute medical unit, I can remember in Bay 4, right, last bed on the left, who were treating with coamoxiclav, who had worked as Fleming's lab assistant. 71-year-old retired man with complete heart block, this is from Brighton many, many years ago, who'd spent his life developing pacemakers at St George's Hospital. So he needed a pacemaker put in. Just last week, 56-year-old teacher with an overactive thyroid is the last patient I saw on a Thursday afternoon before I was going to Milan for a medical education conference. I was going to talk on formative assessment. He'd just finished his doctorate on formative assessment. First pilot of a B-52 bomber who had myeloma, pancytopenia, having a blood transfusion after his chemotherapy. I saw him in San Diego on a ward round with an American attending. I remember him because he was the first B-52 bomber pilot ever. So be Greek, going back to the beginning. Tell stories of people to yourself and your colleagues. If you're treating a patient, before you know the person, you're one step towards dehumanizing care. It's one step too far. The bit about repeated introductions, some of you know Dr. Kate Granger, who's got a terminal cancer, who started the movement, Hello, my name is. Doctors and nurses don't say enough to patients, hello, my name is. We now do repeated introductions in our ward round every day, even if it's the same person, we still say, I'm Dr. Caldwell, this is Andy, this is the rest of the team. When I did my elective in Kenya, you had to shake hands with every nurse on every ward in the morning and in the afternoon to get that personal connection. Be sure you know the person before you make them into a patient. Same with our members of staff. Show that we care in this organisation by knowing the people. So, repersonalised clinical care, person to person. Thank you.